bleed, bleed, bleed. And everywhere there is blood. Emerson said, I have all men's blood and all men have my blood. So GI bleeding, there could be nothing more basic to your test than GI bleeding. And GI bleeding means, let's take an example. We have a 76-year-old man, woman with a history of aortic stenosis who's had 5 red, black, red, black, red, black stool, red, black stool, red, black stool. Now, is that red, black stool upper GI bleeding or lower GI bleeding? Well, we don't have a way of knowing, do we? We don't. And the whole point about this is that the nasogastric tube is not useful because no matter what we think this is, the etiology is not as important as the severity. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. So the nasogastric tube can sometimes help us to understand, is this an upper GI bleed versus a lower GI bleed? But that's not as important as us being able to assess the severity of the bleed. Now, how much blood do you have to lose to be orthostatic? How much blood do you have to lose to be orthostatic? Orthostatic means that when you go from a lying flat to either sitting up or standing up, there's an increase in the pulse of 10 beats a minute, or that there is a decrease in your systolic blood pressure of greater than 20 of systolic. Orthostatic means that you've lost 15 or 20% of your blood volume. I saw this yesterday in the hospital. BED attending admitted a man whose hematocrit had dropped from 39% 2 months ago to 28% now. And people went, holy crap, this guy's got blood in his stool, and he dropped his hematocrit. At no point in the emergency room attending's note did they document the orthostatics. At no point in other people's note did they document the orthostatic hypotension. And it would have been a lot better if they had. You see, if you stand the person up and they have an increase in the pulse of greater than 10 beats a minute and a decrease in the systolic blood pressure of 20 millimeters of mercury, this person is orthostatic. They need to be admitted. They've lost 15 or 20% of their blood volume. But they didn't do it because they're not competent. And I thought about this. You know, there are a bunch of, one of the great things about being me is there was like all these medical students volunteering to come in today. It's a weekend day today. And they came in today because they just want to learn medicine. And what was great about it is that they're going to learn how not to screw this up. Because, you see, you don't get to have an increase in your pulse to have a greater than 100 pulse, implying a 30% blood volume loss, or a decrease in systolic blood pressure to where you have a decrease in your systolic blood pressure to under 100 millimeters of mercury until you've lost 30% of blood volume. And this was awesome because it really bothered me that the attending in the emergency room and the medical admitting resident didn't do this. They didn't do orthostatics. Like, if you'd done the orthostatics, you would have understood that although this person had this big drop in hematocrit, they weren't orthostatic. They weren't hypotensive. And this person, in fact, didn't even need to be in the hospital. So they kept the person in the hospital till they developed a Staph aureus infection. That sucks, doesn't it? So if you're a person who's orthostatic, if you're orthostatic and you have, in fact, a decrease in your systolic blood pressure greater than 20 millimeters of mercury, or if you have an increase in your pulse greater than 10 per minute, this person should be scoped right away to say, hey, where's the source of that bleeding? But the other thing is, if the person was not orthostatic, they didn't need to be scoped right now. All you need to be able to do is to be able to say, hey, did you give the person some fluids, normal saline or Ringer's lactate? Did you need to give the person some fluids? Did you need to give the person some blood, some packed red cells? Packed red cells. You see, if you gave packed red cells and you had a hematocrit that was less than 30, you would have given some packed red cells. Did you need to give the person, because they had an elevated prothrombin time, they had an elevated INR, what would you give if you had an elevated prothrombin time and elevated internationalized normalized ratio? What would you give? Would you give fresh frozen plasma? Would you give vitamin K? Would you give cryoprecipitate? What would you give that person if they have an elevated prothrombin time, an elevated INR? What would you give that person? An elevated prothrombin time, an elevated INR? What would you give that person? You'd give them fresh frozen plasma, because that's the fastest way to correct coagulopathy. That's the fastest way to correct coagulopathy. The fastest way to correct a coagulopathy is with fresh frozen plasma or an AK if you have an elevated prothrombin time, elevated INR. I have a person who has orthostasis. I want to give them blood. I have a person who has a hematocrit less than 30. I want to give them blood, packed red blood cells. I want to have a person who has a platelet count less than 50,000, 30 to 50,000, 30 to 50,000. And I want to give them platelets because they are a person who has got fluid loss. They need normal saline or Ringer's lactate. Fresh frozen plasma because they've got a coagulopathy. Dude, you got a coagulopathy and you have an elevated INR or prothrombin time. You got to fix that now. Less than 30,000, less than 50,000 platelets and you're bleeding. Time to give you platelets. Fluid. Blood, hematocrit less than 30, hematocrit less than 25. Platelets, less than 30, less than 50,000. Plasma, you got an elevated INR, elevated PTT. How do I know whether I'm going to replace these things? I need to know I'm going to give you fluids because you have a systolic blood pressure that's less than 90 to 100. Fluids, normal saline or Ringer's lactate. Fluids, blood, packed red cells, packed red cells, packed red cells, packed red cells, because I've got a hematocrit less than 25 to 30%, 25 to 30%. Fluids, blood, platelets, platelets. I've got platelet count less than 30,000, less than 50,000. Fluid, blood, platelets, platelets, plasma, plasma, fresh frozen plasma, because I've got an elevated INR, greater than 1.3, 1.2, 1.4. I've got fluids, blood, platelets, plasma, fluid, bloods, platelets, plasma, fluid, blood, platelets, plasma, fluid, blood, platelets, plasma. It's the answer for the test. It's the answer for the rest. It's the answer for patients who are in the hospital. I gotta tell you, I'm so sad today. I'm so sad today because the stuff I'm saying to you today And I saw 2 GI bleeders today, and the frickin' attending in the emergency room didn't check the orthostatics. I'm like, why didn't you check the orthostatics? If you checked the orthostatics, you would have seen how much fluid this person had actually lost. Second thing is, they didn't check the hematocrit. The person who comes in with a hematocrit, the first hematocrit, never tells the right answer. The first hematocrit never tells. The first hematocrit never tells. You can cut someone's head off. The first hematocrit doesn't tell. What the fuck is wrong with these people? Seriously, the first hematocrit was normal. They didn't even repeat it till the next day. What's wrong with these people? The first hematocrit does not tell. Do a second hematocrit right away. Do I sound upset? Yes, I'm upset. Of course I'm upset. Because isn't this some test-taking bullshit? Trying to take care of people here. The first hematocrit does not tell you the etiology. It doesn't tell you the severity. You have to get a second hematocrit immediately to tell you. Now, in the case I saw today, the second hematocrit was in fact higher. Get a second one, or a third one. Get a third one, second hematocrit, third one hematocrit. Usually it doesn't even need one run. But find out right away. Was the platelet count low? Was the INR high? Fluid, blood, platelets, plasma, fluid. Do I seem too intense for you? Then you shouldn't have gone to medical school. Go work for a hedge fund. Next point, varices. What do you do additionally for variceal bleeders? Esophageal varices. Esophageal varices. The esophageal varices is that in addition to fluids, normal saline Ringer's lactate, blood, hematocrit less than 30, recheck it, platelets less than 30 to 50,000, less than 30 to 50,000, increased INR, get prothrombin, increased INR, prothrombin time, get fresh frozen plasma. You have to also give people octreotide, octreotide. Octreotide decreases portal pressure. Octreotide makes it easier for the varices. Octreotide is a somatostatin analog. Octreotide, and remember, don't forget proton pump inhibitors for upper GI bleeds. 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 Don't forget to add octreotide because octreotide decreases portal pressure. And when you give this for portal pressure, what happens when varices if they continue to bleed? And if you continue to bleed with varices, don't I sound angry? I'm calm compared to what the families feel when their loved one has been mistreated. I'm calm. What happens if that octreotide does not work? What do you do also? Transjugular intrahepatic portal systemic shunting. Transjugular intrahepatic portal systemic shunting. Take a catheter, put it in the neck, and poke a hole in their liver. Transjugular intrahepatic portal systemic shunting. What about beta blockers? When are beta blockers the answer? Beta blockers, the answer, are to prevent the next bleed. They're not for the acute bleed now. They're to prevent the next bleed. That's what beta blockers are for. They're to prevent the next bleed. All right, let's say this again. For all GI bleeds, fluid, blood, platelets, plasma, fluid, blood, platelets, plasma. Check the orthostatics. Check the orthostatics because it'll tell you, have they lost just a little bit of blood? You know, if they're not orthostatic, it means they haven't lost any significant blood at all. They didn't check the orthostatics on my patient today. They didn't check them. They would have found out that the dude didn't even need to be admitted. Dude didn't even have orthostasis. But they didn't do it. And yes, it upsets me. Because we're not here on just test taking, are we? You know why we can get all the answers right on the test? Because we want to help people. Helping people means this. Okay, orthostasis, you need to be in the hospital. Systolic blood pressure less than 100 means you need to be in the hospital. Blood pressure, pulse, blood pressure less than 100, you need to be in the hospital. Pulse above 100, you need to be in the hospital. How do I know what the severity is? Fluids, if you have orthostasis, or a blood pressure less than 100 or pulse above 100. Platelets, if it's less than 50,000 platelets, 30,000 platelets. Plasma, if you have an INR that's elevated or prothrombin time that's elevated. Now, what if there's varices? Untreated. What if you continue to bleed with varices? Tips, transjugular, intrahepatic, portal, systemic, shunting. Take a catheter, poke a hole in their liver with the catheter, and it relieves everything. Fluid, blood, platelets, plasma, fluid, blood, platelets, plasma, fluid, blood, platelets, plasma. See you in the next section.